I will be talking a very simple subject for the ones that are starting arthroplasty. It's an overview on what I think it's important to remember when you think of Hemi, Anatomic, and reverse. And I'm very pleased to be here in Egypt for the first time lecturing in this wonderful meeting. Professor recognized as a big leader and a hard-working man in order to achieve such a success. Congratulations, Professor Hadel. And if my lecture doesn't go, I can sing for you samba from Brazil. I don't know. I'm not a singer, no. Now we are going here. Or we can discuss who will win the World Cup in Qatar in November. This is a very hard topic. Brazil will not win.
Brazil will not win?
No, because we have Neymar. Falling. You see, falling.
A great actor.
Yeah, a great actor. Great actor. Yeah, not a player. Well, good. Thank you, man. Well, my first word here is to remember you next year, September, in Rome. On behalf of the International Board of Shoulder and Elbow Surgery, I invite you for the 15th International Congress of Shoulder and Elbow Surgery, a tradition that started in 1980 in London by Lip Castle and Ian Bale. Well, let's go. Indications for shoulder arthroplasty. Where we are today. Hemi, anatomic, or reverse? What's the science behind this? Just to remember, the early 50s with the partial monoblock, as you mentioned a minute ago, by Dr. Neer, then the Neer 2, and then the total that Neer introduced, among other authors, in the 70s. Then came exactly what you talked about a minute ago, bipolar, modular, and so on. And finally, the reverse by Paul Gramont has changed everything. So these are some things for you to remember. 70 years ago and 50 years ago, the monoblock, and then the first generation of anatomic, then the real anatomic later on, today the reverse. As Dr. Verboog has just mentioned, we have next steps, and that will be soon, because all evolves in our field. Hemi, for the beginners here, not for the professors. 70 years of experience, very easy and reproducible, fast procedure, smaller risk of instability when well done. And when you have to revise, goes to anatomic or reverse. However, we have progressive glenoid erosion, residual pain, and scores get worse with time. Then comes anatomic, since the 70s, 50 years of experience, a great pain relief procedure, better fulcrum. When needs to be revised, goes to reverse, and needs a better learning curve. There is polyethylene erosion and problems mostly at the glenoid site. And finally, the reverse, 30 years of experience, mostly in Europe. Immediate pain relief, immediate range of motion because there is no need for supraspinatus, and also needs almost no physiotherapy. However, it's more expensive, there is a long learning curve, and the complication rate came down ever since, and nowadays is less than 5%. And when you have to revise, it's for experts, not for simple surgeons. This shoulder meeting has announced, has anatomic total shoulder become a lost art in the increase of the use of reverse? Lost art is like Indiana Jones, as you remember. So J.P. Warner in the Codman Shoulder Society has called this the era of reverse prosthesis, as you will see here in a minute. And revisions. This is something that must be considered as well. So there is no place anymore for wrong retroversion or very high implant. This is all past, I suppose. But there's a long learning curve to do it right. It's not just use your fingertips for that. The ACES, the fellowship in North America, requests that in 1 year, the fellow should perform these numbers of arthroplasty in clinical case, elective case, and this number of prosthesis in trauma. So it's a hot subject. These indications today, we may discuss among experts, but on average, when you have a vascular necrosis, still Hemi is the way to go. When you have rheumatoid arthritis, my generation started with Hemi. Then we went to Anatomic. And according to the age, you can do a reverse. 3 and 4 part fractures, we will be discussing this in this room later on. Before was Hemi, now reverse. Arthritis after trauma. Before I used to do total. Now depends on the age, I do reverse. And primary osteoarthritis, the same. Usually total is a great procedure, but the patient is old, reverse. Bone tumors, mostly reverse nowadays because you have to take everything out, including muscles. When it fails, the Hemi and Anatomic, you do a reverse. And finally, the big golden standard indication is the cuff tear arthropathy. When you cuff fail, you go to reverse. So, look, it's a lot of reverse here, but this is how literature shows us nowadays. So yes, it's the era of reverse. In the orthopedic summit that I participate, and this is Evan Flato here, Verbo, you see, right in the center. There was an expression that Dr. Gulota said, my right anatomic was terrible, and my reverse is great. Why don't we just do a reverse? Patients ask for reverse. This is what this slide means. So, and also Tony Romeo, in a recent meeting sponsored by Stefano Gumina, the experts, has classified us, surgeons, according on what we like to do. And this is kind of neat. We have the innovators here, the very first ones. Then, but nobody pays much attention here, the innovators. Early adopters, well, let's do it. Then come most of us, early majority. Later on, the late majority. And then comes the ones that will never believe in what is going on and are always 10, 15 years back in time. So, this is something that happens with the indications here, yes. And when we see numbers, it's tremendous. 60% of all sales in arthroplasty nowadays is reverse. 36% are anatomic, sorry. And almost nothing, I mean, just a small piece is hemiarthroplasty. This shows a trend, and this is important to understand. So, reverse is the time. Total and much less Hemi. And according to the age, you know, the guy, it's 60, 78, more than 80 years. According to the age, the reverse gets higher and higher indication. That's no question about. I cannot do still an outpatient procedure for shoulder arthroplasty, but few centers are doing this nowadays in order to save money. I'm not in this field. I'm not the early adopter of this procedure. My patients stay 1 to 2 days in the hospital yet. But let's go back a few years. This gentleman passed away early this year, Charlie Rockwood. Everyone loved him. And he was the one to support Hemi as the key for the success. Significant improvement in all parameters. And I remember him stating this very strongly. Well, that was back in 2007. So later on, his friend, Dr. Madsen, has reviewed almost 400 cases, hemiarthroplasty reviewed. So what was wrong in these cases? Rotator cuff insufficiency, malpositioning, glenoid erosion, greater tuberosity unhealed, and mostly patients were female. So there's a big learning curve here. In order to avoid revision, do adequate retroversion and the height of the implant and soft tissue balance. This cannot be taught in a lecture like this. Anatomic, not Hemi, in cases when the glenoid is involved, and reverse in all cases of rotator cuff deficiency. So, with these papers, it's easy to understand that Hemi is not an option anymore for these cases. Those are more than 30 years old slides of my own. This is a Hemi for a very mild osteoarthritis. This lady had an excellent result. Not all my Hemis have this result for sure, but I'm happy to show this. This is rheumatoid arthritis that I made hemiarthroplasty in both sides. Later on, I had to revise. This is a farmer with an advanced osteoarthritis, 6 years in pain and limited range of motion. We performed an hemiarthroplasty. And guess what? 1.5 years later, pain increased, motion decreased, there was no infection. Which is the hypothesis here? Very simple to understand. Glenoid erosion. It was like that. So we remove it, we revise it to a total anatomic. Since this patient, that was back 20 years ago, we discussed in our team no more Hemis for osteoarthritis because we will always have this bad result, and we change our minds in those days. This is a paper comparing Hemi and Anatomic. This one here says the Anatomic or total has a better function and less pain. And this second paper says the same. So it's kind of repetition. Here is a lawyer, 65 years. Again, 3 years with pain and limited range of motion. And we did anatomic or reverse. Pure eye, no technology. And here is the patient doing pretty well. Happy, never need a revision. Still happy with the procedure. Here is another one, almost the same thing. Osteoarthritis, we did a total, and the patient went well. Then we have a evolving technology here. The humeral components went stemless, and the stem was smaller and smaller. And this has something important for us to understand. Similar scores and complication rate when compared with studies with a long stem. And this other study, very recent one, says the same, and shorter operative time and less blood loss. And finally, we reach the reverse, which for the beginners means medializing the center of rotation and lengthening the deltoid. Well, this is a failed rotator cuff tear, got cuff tear arthropathy. We made a reverse, and here is the patient, very happy. Oops, oh, failed it. And then, sorry, but here is like 8 years post-op, the patient has the same movement, very happy. Sorry to. This is a patient with cuff tear arthropathy, big degeneration of all muscles. And this is the day that the patient went to take the stitches out, around 15 to 20 days. The patient was able to raise the arm and no pain. That was a miracle for us. It's not common, but that can happen. Okay. Complications and pitfalls. In 500 cases, 13% were Hemi, 7% anatomic, and only 4% reverse. And finally, let me tell you about our situation in Brazil. We are 18,000 orthopedic surgeons in the country. Our shoulder society has now 1,100 members. Half of them usually do 2 arthroplasties per month. And almost probably a third of those, about 150, is able or is well trained to do a revision arthroplasty in a very correct way. So revision arthroplasty is something serious. So when you do an arthroplasty, you have to think that this prosthesis probably is going to be revised sometime. So the learning curve tells you what to do. With the life expectancy increasing, more and more arthroplasties will be done. And the idea is to reduce pain and increase mobility. And for that, we need training. Oops, failed. Thank you.